Hello everyone. Today's lecture mainly covers the diagnosis of intestinal obstruction. First of all, what is intestinal obstruction? Intestinal obstruction refers to the obstruction which prevents the normal movement of intestinal contents due to any cause, and it is one of the most common surgical acute dominance. In clinical practice, it is divided into mechanical, dynamic, and vascular intestinal obstructions by incidence causes. In addition, it can also be divided into simple intestinal obstruction, without vascular disorder, and strangulated intestinal obstruction, with hemodynamic disorder, depending on whether there is hemodynamic disorder in the intestinal wall. Strangulated intestinal obstruction may lead to intestinal necrosis and perforation if not treated timely. Besides of obstructions, it is divided into upper small intestinal obstruction, lower small intestinal obstruction, and chronic obstruction. By severity, it is divided into partial and complete intestinal obstruction. By urgency, it is divided into acute and chronic intestinal obstruction. Intestinal obstruction with both ends of intestinal loop pressed and obstructed is closed loop intestinal obstruction, featured by highly distended intestinal canal and rapidly increased pressure in intestinal canal, more easily causing hemodynamic disorder of intestinal wall and intestinal necrosis and perforation. Both chronic obstruction and volvulus are closed-loop intestinal obstruction. After one of the intestinal obstruction, the accumulation of gas and liquid is the enteric cavity above the obstruction causes the intestine to swell and the pressure in the cavity to rise. The intestinal distension is the basis of local change and systematic physiological disorders caused by intestinal obstruction. The lower the obstruction site, the longer the obstruction, and the more obvious the intestinal distension. The intestinal distension causes abdominal pain, abdominal distension, vomit, and stop of loss and defecation, as well as water and electrolyte disorder, acid-base imbalance, infection and toxicity, shock and respiratory and circulatory dysfunction. If the cause is not removed in time, progressive intestinal expansion will eventually lead to hemodynamic disorder of intestinal wall, intestinal necrosis and perforation peritonitis, septic shock, SIRS, and even multiple organ dysfunction. Therefore, early diagnosis and timely treatment of intestinal obstruction are of vital importance to every surgeon. A complete diagnosis of intestinal obstruction should include the determination of the causes, site, and severity of obstruction, the urgency of onset, and whether there is hemodynamic disorder of intestinal wall. The causes, site, and the severity of intestinal obstruction, as well as the urgency of onset, vary with different cases, thus making the clinical manifestation of intestinal obstruction complex and variable, and making it difficult to make a complete and accurate diagnosis in time. When diagnosing intestinal obstruction, first of all, it is necessary to determine if there is an intestinal obstruction. If confirmed, the type, for example, simple or strangulated intestinal obstruction, and nature of the obstruction need to be determined according to the clinical characteristics. Finally, the site and the cause of the obstruction needed to be identified. First of all, determine whether it is intestinal obstruction. The surgeons should inquire about the medical history and carry out careful physical examination and necessary accelerate examination. Comprehensively analyze whether there are typical symptoms and signs of intestinal obstruction. All types of intestinal obstruction are featured by the obstruction of movement of intestinal contents with classic clinical symptoms, including abdominal pain, abdominal distension, vomit, and stop of fluids, and defecation, and abdominal distension, visible peristalsis, peristaltic, wave, and hyperactive bowel sounds found in physical examination. Strangulation may be manifested by peritonitis. The abdominal X-ray is one of the most common used auxiliary examination methods in clinical, which shows intestinal loop flatulency and gas fluid level 4 to 6 hours after onset. The obstruction can be located according to the different X-ray signs. It is not difficult to diagnose intestinal obstruction with above typical symptoms, signs, and X-ray manifestation. Other types of intestinal obstruction, like partial intestinal obstruction and early-stage strangulated intestinal obstruction, are easily to be missed or misdiagnosed due to their antitypical symptoms and signs and need to be repeated observation and comprehensive diagnosis. Number 1. Dynamic observation of clinical manifestation. There are many types and combinations of intestinal obstruction with completed and varied manifestation. Be careful not to miss the intestinal obstruction with incomplete or antitypical symptoms. The nature and degree of abdominal pain vary with the types. Paralytic intestinal obstruction is manifested by persistent distinct pain. Mechanical intestinal obstructions by paroxysmal chronic pain. And strangulated intestinal obstruction by persistent sharp pain accompanied by paroxysmal aggravation. The vomit and abdominal distension of pain-suffering intestinal obstruction at different sites also vary. The patients with upper intestinal obstruction may experience early and frequent vomit, with volumes of intestinal contents and non-obvious abdominal distension. The patients with lower intestinal obstruction may experience late vomit and obvious abdominal distension, with vomitus of feces-like intestinal contents in bowel or of bloody, suggesting hemodynamic disorder of intestinal wall. The time of stop of fluids and defecation is related to the completeness and position of the obstruction. The patients with lower complete intestinal obstruction may experience stop of fluids and defecations at early stage. For patients with complete upper intestinal obstruction, they may experience normal fluids and defecation until the exhaustion of the excrement and gas accumulated in the intestinal canal below the obstruction. Be careful not to misdiagnose as partial intestinal obstruction or miss as the patient with partial intestinal obstruction may suffer mild abdominal distension and vomit with persistent fluid and defecation. Number 2. Find out whether there is cause of intestinal obstruction. The most common in clinical is mechanical intestinal obstruction, often caused by intestinal adhesion, tumor, incarcerated strangulated hernia, and intussusception. Physicians should ask for relevant medical history of abdominal surgery, injury, or infection, and whether there is reticulate mass at leg or perineum. Number 3. Perform careful physical examination and do not leave out special parts. Note whether there is surgical incision, visible peristalsis, peristaltic wave, and abdominal asymmetry. Palpation in case of simple intestinal obstruction and distension of the intestinal canal stimulates the visceral nerve. Mild pressing pain and can be felt without signs of peritoneal irritation. In case of strangulated intestinal obstruction, due to the severe intestinal swelling, fixed pressing pain and signs of peritoneal irritation can be felt, and the mass with pressing pain is usually ischemical strangulated intestinal loop. Percussion. In case of strangulated intestinal obstruction, the shifting dualness is positive to do extrication. Auscultation. In case of mechanical intestinal obstruction, the hyperactive bowel sounds features gurgling or metal sounds, and paralytic intestinal obstruction features weaker or even diminished bowel sound. In addition to careful abdominal examination, attention should be paid to the examination of lingual region and leg, and that are predilection sites of incarcerated strangulated hernia. Do not leave out rectal touch, which helps to identify the cause of intestinal obstruction and determine whether the intestinal obstruction is strangulated. Number 4. Laboratory examination. Simple intestinal obstruction, only dehydration, electrolyte, and acid-base disorder are manifested. Strangulated intestinal obstruction. It is may be fascinated by an increase in the total white blood cells and neutrophils in addition to aggravated dehydration. Electronic and acid-base disorders. Vomits and feces contain a large number of red blood cells under a microscope or fecal occurrent blood test positive, and liver and kidney dysfunction. Number 5. Examination. Abdominal X-ray films. Intestinal loop, fecal and gas fluid level 4 to 6 hours after onset. Manifestation of X-ray films vary with the size and types of obstruction. It should be noted that the gas fluid level can also be seen in intestinal status caused by acute appendicitis, peritonitis, cholecystitis, pancreatitis, and pelvic inflammation. Inflammatory stimulation can cause reflective status of surrounding intestinal canal, resulting in pneumatosis and effusion in intestinal tract, which are transient intestinal absorption and peristalsis dysfunction, and can be eliminated after treatment. The width of gas fluid level of intestinal status is shorter than that of intestinal obstruction, usually no wider than 3 cm. In addition, the beam mode ultrasound and CT examination can clarify the nature of lesion focus, helpful for identification. Secondly, determination of simple or strangulated intestinal obstruction is the most important in the diagnosis of intestinal obstruction. The diagnosis concerns treatment method, and prognosis and surgery must be performed as soon as possible upon confirming strangulated intestinal obstruction. Following indications may suggest a likelihood of strangulated intestinal obstruction. Abdominal pain is categorized by quick onset, with persistent severe pain at beginning, or persistent pain between paroxysmal aggravation, lumbago, and backache may occur occasionally. Number 2. The disease develops rapidly with shock at early stage, and anti-shock treatment after anti-shock treatment takes little effect. Number 3. It is manifested by peritonitis with higher temperature, rapid pulse, and increased white blood cells count. Number 4. Asymmetrical abdominal distension with local bulge in the abdominal or mass with pressing pain. Number 5. Vomit occurs in early stage and frequently with bloody vomits, gastrointestinal decompression, extract and discharge through anus. Bloody fluid is extracted by abdominal cytensis. Number 6. The abdominal X-ray film shows an isolated enlarged intestinal loop. Number 7. There is no significant improvement in the signs after active non-surgical treatment. The simple and strangulated intestinal obstruction are distinguished mainly by clinical manifestation and X-ray manifestation. And strangulated intestinal obstruction features hemodynamic disorder of intestinal obstruction. So CT and angiography examination that can directly identify hemodynamic disorder has higher diagnostic significance than that of normal abdominal X-ray. Sometimes it is difficult to distinguish strangulated intestinal obstruction from simple intestinal obstruction, commonly seen in the case of compression necrosis of intestinal wall caused by the adherens choroida and incarcerated partial hernia and partial intestinal wall strangulated. Therefore, exploratory laparotomy should be performed for patients suffering simple intestinal obstruction with abdominal pain not alleviated after a short time period of non-surgery treatment. The last step in the diagnosis of intestinal obstruction is to determine the site and the cause of the obstruction. As the cause of intestinal obstruction may be difficult to determine, it is necessary to conduct comprehensive analysis on patient age, medical history, physical signs, laboratory examination data, and X-ray film. Clinically, adhesive intestinal obstruction is the most common type, accounting for about 50% of all intestinal obstructions caused by tumor, and internal and external hernia account for 50% respectively, and remaining times are caused by other rare causes or factors. A patient with intestinal adherence has medical history of abdominal surgery, injury, or abdominal infection. Congenital malformation is the predominant cause of intestinal obstruction in newborns, and intussusception is more common in children aged below 2, while intestinal obstruction in aged people is usually caused by tumor or facial mass obstruction. After all, diagnosis of intestinal obstruction treatment program should be determined according to the causes, nature, site, systematic condition, and severity of lesion. For intussusception and early stage, perileak intestinal obstruction, and simple adhesive intestinal obstruction, non-operative treatment may be adopted, including fasting, gastrointestinal decompression, correction of water and electrolyte disorders, axis-based imbalance, infection prevention, symptomatic treatment, and nutritional support. Intussusception at early stage can be reduced by lower pressure barium enema or air enema. Surgery should be performed for intestinal obstruction caused by extensive adhesive, intestinal obstruction, intestinal tumor, malformation of intestinal, and other organic disease without response to non-operative treatment so as to remove obstruction and cause. Surgery should be performed for strangulated intestinal obstruction before intestinal necrosis. Okay, let's make a conclusion. The intestinal obstruction refers to the obstruction which prevents the normal movement of intestinal contents due to any cause. The intestinal obstruction is typically manifested by abdominal pain, abdominal distension, vomit, adenal defecation, and passage of gas by anus. The X-ray film shows intestinal flatulence and gas fluid level 4 to 6 hours after onset. Whether there is intestinal obstruction, whether it is a strangulated intestinal obstruction, and the site and the cause of obstruction should be determined in sequence, and a treatment program should be based on the patient's conditions. The physician should conduct repeated observation and comprehensive analysis on the intestinal obstruction that is difficult to diagnose and make bold hypotheses and cautions vertification.